Next comes the question of how to go about the design process. It is not simply a matter of placing the components where they are supposed to be. It is not that you see a case and it's like, okay, I have 0.01 inch undercuts here. I'm not supposed to place the undercuts here and basically go about just placing the rests and the meshes and the major connectors in a very robotic or mechanical fashion. You have to look at the patient as a whole, see what the patient's needs are, see what the oral cavity's needs are, and incorporate some principles in your design so as to make sure that the prosthesis not only serves the function of rehabilitation and maintenance of oral health, but also make sure that it is going to contribute to prevent further deterioration of the patient's oral cavity. Now, of course, the principles are straightforward and theoretical. They are based on thorough foundational knowledge. You do a proper examination and diagnosis of the patient, you chart out a proper treatment plan, you restore the form and function, and of course, you go about maintaining the oral health so that the patient can have a good function and aesthetics. Now, philosophies are basically what are the schools of thought you would apply in your cast partial design, right? And those are of three in nature: broad stress distribution, stress equalization, and physiologic basing. Now, these basically are there to say that it is not just you do a partial design in a very methodical way. It is also that you look at the patient's mouth and you incorporate certain elements, or you would swap out certain components for other components in favor of protecting the patient's overall oral health, right? Now, of course, broad stress distribution, stress equalization, and physiologic basing. What is broad stress distribution? Now, the idea is you distribute the stress over as wide an area as possible because proponents of this philosophy basically thought, you know, if I'm going to have weak teeth and mucosa that is going to resorb on load, I might as well use as many abutments and as much tissue coverage as possible and thereby spread out the area on which I'm applying the stress. So large force distributed over large area is actually less pressure, right? So that's what their idea was. So they have broad major connectors or big major connectors like the AP spread, AP strap, or the complete palatal coverage, and they use multiple rests. More than that is just on the direct retainers, clasp assemblies, or the indirect retainers. They also give secondary or auxiliary rests on multiple teeth. And the advantages of this particular philosophy are that it provides a great degree of periodontal splinting and bracing effect against a lot of horizontal forces. But with this much coverage, obviously comes a lot of discomfort for the patient because they feel that the entire cast partial is sitting, occupying the space inside their mouth. Now, stress equalization was another philosophy which was based on the idea that the mucosa always has much greater degree of compressibility and movement compared to the teeth. So, proponents of this school of thought whatever you do to the CPT, it is always going to end up loading the teeth more than the mucosa, and the teeth are going to get damaged. So, what they said is you incorporate some kind of a hinge or a stress breaker between the teeth and the cast partial so that the stress breaker will bend or move to take up the force and dissipate it into the bone rather than allowing it to go ahead and damage the teeth. So it uses hinges or stress directors to minimize loading, right? And you will use a very minimal amount of direct retainers on in this kind of philosophy, right? The idea is that these hinges would allow denture based movement and allow for some degree of flexibility on occlusal loading. Now you can use cylinders, ball and sockets, or all your intracoronal retainers which have like silicones or other kind of cushioning elements in them would be an example of stress equalizing philosophies. The advantage, of course, is that it is going to load the teeth less and thereby save the alveolar bone. But the problem is that these components are usually very delicate, and if they break, they're extremely difficult to repair, and the fabrication process as such is not going to be very easy. Last comes physiologic basing. Now, the physiologic basing idea is that the mucosa is going to displace more, but if you are going to be able to load the mucosa during your impression procedure, then it is when the patient is going to bite, that is basically the state in which the denture base is fabricated, and so the mucosa is optimally loaded when the patient is using the denture or when the denture is in function, right? So on biting is when the bone is in an optimal or the tissue is in an optimal function is the idea behind physiologic basing. Now, the method by which they did this was they used minimal retentive features, right? Combination clasps when possible. And they used a muco-compressive impression technique so that they compressed the mucosa and loaded it and recorded it in that state. Now, the advantage with that is that obviously the vertical forces are tolerated well. But the disadvantage is once the denture is released out of function, the mucosa tends to rebound and relax. So at a relaxed state, the CPD is always, and the occlusal surface of the CPD is always at a level that is slightly above the remaining occlusal plane. So if the clasps are made to engage the teeth, then they would be engaging the teeth all the time and cause periodontal damage. If not, the patient would always have like a premature contact, and then the cast partial denture would seep into occlusion. So this philosophy was again, a kind of a cat on the wall philosophy. But the idea was that all these three philosophies are kind of incorporated different layers of the cast partial design process. In reality, we do accept these philosophies and try to incorporate them and have a base idea of them in our mind when we design a case. For example, the horseshoe shaped major connector is not preferred when we design posterior teeth or distal extension cases because they flex and tend to load the mucosa quite a bit. We also do prefer to give rests on sound natural teeth and not on teeth which are periodontically compromised. So it's not that these concepts are only theoretical. We do apply them, but not in the form or schools of thought that they were earlier proposed. Right? So these are already a part of the standard design process. All right. So what in the finality, or what does a final cut retake? So at the end, what does a design for a Kennedy's class 1 or a class 2 situation actually look like? So one of the key features is that, of course, it is going to restore the form and function. And this is even more important than actually retention or clasping in a particular case, right, in the distal extension scenarios. Now, the second important thing would be that there is going to be direct retention, and this is going to use something called as a bipod configuration, right? Class 1 case is going to use a bipod configuration, meaning it is going to engage one abutment tooth on each side. So here you see that it is going to engage this tooth and this tooth. So that is a bipod. If this were a class 2 case, and say for example this side were dentulous, you would have a tripod configuration where you would have this tooth being engaged, the anterior most tooth and a posterior most tooth on this side would have been engaged. So that makes a tripod configuration, right? So in a dentulous side, you have two clasp assemblies, one as anterior and one as posterior as possible on the intact side. And of course, on the edentulous side, you will have one on the distal most abutment tooth. So in toto, the class 1 has a bipod clasping, whereas a class 2 Kennedy's case has a tripod kind of clasping. And when we come to support, the abutment should provide a good degree of support, and you should take support from the distal abutments on both sides. Onto the ridge, you will be extending it to the physiologic limits because the mesh always extends to tuberosity or 2/3 of the distal extension span in case of lower arch. And there are specialized impression techniques to be able to record as much of the ridge area as possible, which we'll be discussing soon. And we have to load it within the functional limits and cover as broad areas as possible and take as much support as possible in these distal extension cases. In terms of indirect retention, we will be using perpendicular rests or auxiliary rests in a direction perpendicular to the axis of rotation as far anteriorly as possible. Now, for reasons discussed earlier, we obviously cannot load the incisors because they are labily placed and their roots are small. The canine again has a sloped surface, and even an axial force on a sloped surface vector resolutes into a sloping force. So the canine is not preferable. So that would end us on a second compromise, and we basically load the mesio-occlusal fossa of the first premolar, so which is the usual indirect retainer in a distal extension scenario. And of course, you will have a rigid major connector. cut record. And of course, the last criteria, you will have a very rigid major connector. You will have a good aesthetic. There's no point in giving a restoration that looks ugly. Proper occlusion, and all the minor connectors, except of course approach arm of your bar clasps, would be rigid as well. Now, if the same were a Kennedy class 3 situation, and or in this case a Kennedy class 3 mod, the requirements would be slightly different. Of course, you could treat it almost like a fixed partial denture case. You would have rest assemblies or clasping assemblies on all the four abutment teeth, which would make it a quadrilateral configuration. It is going to be fully tooth borne, and for this reason, you don't expect any tipping force or lifting forces, and hence indirect retention is not required. You will need rigid major and minor connectors, and of course, aesthetics and function will be maintained. Now, class 4 case is slightly unique because in these cases you have a tipping force that is generated from the anterior teeth. So you expect kind of lifting up at the distal ends, which is why if you notice in this case, they have given clasp assemblies on the distal most teeth, so that any tipping force from here is is balanced off by the assemblies on this and this. Retake. So if you notice a Kennedy's class 4 situation, it is unique because you have the anterior edentulous area, and when the patient bites on an end-to-end relation or when he's chewing something, there is a lifting force that is present on the distal area of the tooth. And to counteract this, you have two clasp assemblies located in the distalmost aspects of the teeth, right? You will also have retainers that are present on the teeth that are adjacent to the edentulous area. So that also makes it a quadrilateral kind of configuration. Your design is going to be designed in such a way that it is minimizing the tipping forces in the anterior region. Now, indirect retention might not be required, but if required, they are of course going to be present in the posterior region. If the anterior edentulous span is very big, you would prefer a functional impression so that the limiting structures, the freen are all captured properly and you get a denture base that is not going to be traumatizing to the limiting structures of the mouth. All right, so let's just go back to the tooth tissue support, right? I told you that the saddle areas are going to benefit